So I was asked to speak about, to do a bit of an update on the big conferences that occurred this year, specifically, focusing mostly on the International AIDS Conference that took place in Melbourne in July, as well as CROI, which is the big scientific academic conference that took place in Boston in March of this year. Here are some disclosures. And in terms of my acknowledgements, I'd like to thank, like I said, ACT for inviting me to speak tonight and for making this evening possible. The event sponsors who were listed earlier on the earlier slide. ViiV Healthcare supported my attendance at the International AIDS Conference in Melbourne this year, so I'd like to thank them. And I also stole some slides from some folks. So Dr. Daryl Tan, who did, I think, this forum last year, he provided some slides. I stole some from him. Dr. Fiona Smale from Hamilton, stole some from her. And I stole some from the internet as well. So Clinical Care Options, which is a great resource, I stole some slides from there. And I couldn't go on without acknowledging the place that has been my home for the last 15 years and all the people in it. So I'd just like to acknowledge Toronto and all the people who've sort of been a part of my training and a part of my life here. It's been, I almost feel like I'm talking about a partner here, but it's been the best 15 years of my life so far. So I just wanted to acknowledge the city that kind of molded me into the person I am at this point. All right, so let's get started. So here's a bit of an outline. So I'll talk a little bit about cure research. So there have been a few updates and a few developments this year in the domain of cure research. Then I'll jump into some drug stuff. So I've divided it up into sort of 3 areas here. So first-line therapy. So drug therapy in those who have never been on therapy before. So what do you start in people? Then some novel agents, so some new medications that are coming down the pipelines. And then I'll do a little bit of stuff on a couple of slides on switch studies. So people who are already on therapy and for whatever reason switch to something else, how do those people do? I'll talk a bit as well about some prevention stuff because there's a lot of really interesting prevention stuff that came out this year and a lot of very interesting prevention stuff that's ongoing, both internationally and in Toronto as well. And then I'll talk about comorbidity, so a few things that sort of associated issues of relevance in healthcare. And again, this is not a movie, so you don't need to see the end necessarily. There's a lot of slides. I put in more slides probably than I needed. So 2 hours is a long time to listen. It's a long time to talk. So I'll go, sort of as long as we can. So there's no need to finish everything. By all means, if you guys have questions, jump in, ask me. If you want to spend time talking about something else, or if you don't like the direction I'm going, let me know. I'm very flexible. So I just want to throw in the slide here. As many of you probably remember, at the time that the AIDS conference in Melbourne was starting, there was a tragedy with Malaysian Airlines Flight 17. That was shot down over Ukraine. And several people on that flight were actually heading to the conference. And one of those people, so there were many people here, they're all listed on the slide here, but many of these people, one of the people who was on this flight was Yip Lang, who was very well known internationally, had done a lot of work specifically in access issues for treatment on a global scale, and he was also a former president of the International AIDS Society. So very well known, very important person in the area of research. So I just wanted to put this slide up here to dedicate something to them. The International AIDS Conference happens every 2 years. So it alternates with another conference called IAS, which is a bit more of a scientific conference. The International AIDS Conference is a big conference. It's huge, and it has a big focus on the science, but it also has a big focus on activism, on community-based organizations, and a lot of other things. So it's also the conference where if you've been to them in the past, they have the Global Village. So they have a lot of there's a huge presence there. And at every conference, they have a declaration. So this year it was in Melbourne, so there was a Melbourne declaration. The theme of the conference this year was Nobody Left Behind. And I just included here on this slide a paragraph from the declaration, which I thought captured a lot of the important issues that were discussed at the conference, but also highlighted a lot of the things that are very relevant to how we're taking on HIV research and care these days. So I'll just read it to you. So it went in the end, in conclusion, we reaffirm our unwavering commitment to fairness, to universal access to healthcare and treatment services, and to support the inherent dignity and rights of all human beings. All people are entitled to the rights and protections afforded by international human rights frameworks. An end to AIDS is only possible if we overcome the barriers of criminalization, stigma, and discrimination that remain key drivers of the epidemic. We'll start with some big picture numbers here. So here's a graph basically looking at the global number of people living with HIV and HIV-related deaths from 1990 to 2015. So this is sort of a good news slide, because if you look at the, if I can, here it is. Okay. If you look at the blue graph here, that's the estimated number of people living with HIV in the world, in millions. And you can see basically from 1990, as you go across time to 2015, we're not quite there yet. You can see it's leveling off, but it's still continues to go up. And some people would look at that and say, oh, that's bad news. The number of people living with HIV is increasing. But it's actually not, because that's a total number, right? So that's certainly, it includes new infections, but it also includes those people who are now healthy and living longer. So that's why that number is going up a little bit. If you compare that to the number of deaths, that's actually nicely going down here, and that's in the orange or yellow, however it's projecting here. So you can see this in this lower graph here. The numbers here, at least since the mid-2000s, are dropping. So good news. And then in terms of new infections, the numbers are similar. So both overall numbers in blue and new infections in children, so numbers of new infections in children in orange, also going down. So good news slides here. But again, there are many key challenges, and there are many things we need to keep in mind. So 34 years on, there are sort of three major challenges that we're facing. There are many more than three, but here are three that I'll highlight, and three that we're focused on at the conference in many different ways. So number one, dysfunctional health systems. And what that means is that basically failing to convert treatment and prevention interventions that work. Basically, if you have a health system that isn't working for whatever reason, even if they have effective treatment and prevention mechanisms in place, those aren't going to work if those delivering them aren't functioning properly. Number two, which I think is probably one of the most important, most new HIV infections now occur in key populations, and these should function as the highest prevention priority. So again, young women in Africa are the highest risk group worldwide. And in terms of new infections occurring, the highest rates of infection are occurring in young women in Africa. Part of this has to do, of course, with the fact that not just in Africa, but in many parts of the world, women don't hold the power in sexual relationships. So when it comes down to it, they're vulnerable for that reason. There's a number of other reasons as well, but that's a key driver. Sex workers, MSM and transgender individuals, that's no surprise, because in the Western world, in North America and in Western Europe, MSM are disproportionately affected by the HIV epidemic, and persons who inject drugs as well. And finally, stigma, discrimination, and legislative hurdles. That's another big one, and many of you may have been made aware earlier this year. So it came out around the time of CAR, which is the big Canadian HIV research conference. There was a criminalization position statement, which was co-authored by Mark Tyndall, who was in Ottawa, now in Vancouver, as well as Mona Lutfi. So that was a big sort of development on the Canadian side of things in support of non-criminalization. All right, a little bit on cure. So this is a common question I get in clinic. What's new in cure research? So here are some updates. So going back to 2013, so last year at this time, when Daryl gave the talk, he probably talked about this, and he probably had this very slide because I stole it from him. So in Atlanta in March of 2013, the CROI conference, so the big academic conference in the US, was held. And that's when this Mississippi baby was first talked about. And that's when it came out in the news. And you can see here the headline from the Globe and Mail, which was published on March 3rd, "Doctors Cure US Baby Born with HIV in Potentially Groundbreaking Case." So that was huge news. That was the news of the year, basically, last year. So fast forward to July 2014. The baby again. And it was reported at this time that this baby who had been cured actually now had detectable HIV. So this was a baby who actually wasn't on treatment and was felt to have been cured because she wasn't showing any evidence of HIV at the time, having not been on treatment. And then last summer, it was noted that no, in fact, there was evidence of HIV ongoing. So that was published widely. So that was, that was a disappointment to many people who were doing this type of research. There's just a bit of a summary slide about some cure stuff. So I mentioned, down below here, where is it? The baby now has detectable HIV, so the cure that was initially felt to be real actually isn't. So currently, really the only person who's ever been considered cured is the Berlin patient. So who many of you may know, Timothy Brown. So he's as many of you may know as well, he's the person who had a stem cell transplant or a bone marrow transplant, high dose chemo, and following this was found to be free of HIV. So to this day, he's really the only person who has been essentially cured. There were some other patients who had stem cell transplants in Boston, and there was some hope and there was some thought initially that they might have had the same outcome, but they actually ended up having a detectable virus later on as well. Other things to sort of note on this slide. So there have been a few sort of disappointments, and there have been a few challenges in cure research, and it's a very complicated. It's a very complicated area. Really, the key thing, and you can see it at the bottom right-hand corner, right? Bottom right-hand corner of this slide. That really focuses on the main challenge that is present in cure research now. And it's basically this whole idea of latency. And what does that mean? So to put it in very simple terms, it just means areas that are sleeping. So you have cells that are latent, and they might be infected with HIV, but they're latent. So they're sleeping, nothing much is happening with respect to those cells. And as a result of being latent or sleeping, they're not accessible to things like medications that would normally get rid of things. So one of the key challenges is how do we reach, another term that's used is latent reservoirs. So one of the key challenges is how do we reach these areas that are sort of in a fortress, they're guarded from sort of any interventions that we do. How do we reach those areas to eradicate HIV from these areas? That's really one of the key challenges in cure research, right? So there are a lot of therapies that target these latent areas and try to sort of wake them up and make them active so that medications and other things can fight the battle. But that's really one of the big challenges in cure research. But despite all the setbacks, there is work that's carrying on. And so there's this big group called the AIDS Clinical Trial Group, ACTG. They do a lot of trials. And they have these sort of completely meaninglessly named studies that are going on, but the studies aren't meaningless, it's just the names. So, ACTG A5135, whatever that means. So that study is ongoing. And there's this drug called romidepsin. Not important to know really what kind of drug it is, but this is one of the molecules that can potentially stimulate this latent HIV area, right? These areas that are latent, these areas that are sleeping, which would then allow for possible eradication. So that's one study. There's another drug with this long name, as you can see there, which may strengthen the immune. So there's this idea that, the immune system might become fatigued in fighting HIV. So if you can kind of wake it back up with some sort of drug, and that drug coupled with something else, let's say maybe a vaccine, maybe this could lead to the clearance of HIV. So that's another study ongoing. I think most of these studies actually are still enrolling, actually, in the US. And finally, ACTG A5308. So that study is actually, so recognizing that there are some individuals who are HIV controllers, so elite controllers. You may have heard that expression before. And we know that in many of these individuals, they have a smaller reservoir. So they have a smaller area that's kind of sleeping, or they have a smaller area that's not accessible. And these are people who, are HIV positive, but they can maintain an undetectable or near undetectable viral load without any medications. Something about their immune system that allows them to do that. So, and we know that in these folks, they have a smaller reservoir. So the study that's ongoing now is looking at whether or not providing them with combination antiretroviral therapy can further reduce this reservoir, so make it even smaller. So those are three sort of very exciting, groundbreaking things happening in cure research now. Moving on to drugs. All right, so this is one of those busy slides I promised. So again, you can see a common theme here. ACTG is the group that does these studies, and it's the group that did this study. So basically, what this is so the next couple of studies that I'm going to present are all in people who were not yet on therapy, so they've never been on HIV therapy before, and they're starting. So these are studies of people who are new starts. Okay, and this first study here is actually looking at 1,800 people. And about 600 of them each, so 605, 603, a third of them go into one of three arms of the study. Okay, so what they do is they're going into one of three arms of the study. And as you can see here, I'll talk a little bit more specifically about what medications they're taking. But the medications that they're going on to, the combination medications that they're going on to, are all currently available standard therapies. So the question you might ask is, we already know these drugs work, right? They've been studied before. These aren't new drugs necessarily. One of them is new-ish. So what's the point of doing this, comparing these drugs to each other? So one of the things about these kind of studies is, and it's important to know, one of the reasons these studies get done is, there's a lot of medications out there. And, of all the approved medications, if you look at guidelines and see, from the list which medications are approved and which medications work, they all work, and with very few exceptions, it doesn't, unless there's an issue of, someone's not tolerating something for whatever reason, or if someone is on another medication that might interact, or if someone has another medical illness that might prevent them from taking a certain medication, ignoring that stuff, and if those things aren't an issue, with very few exceptions, it doesn't really matter what you take. As long as you're taking something that's been proven to work and you don't have any other sort of contraindications or reasons to not take it, it's going to work, right? So one of the things that we do is, these guidelines, and these guidelines recognize this. They say, individualized to, each patient based on preference and that sort of thing. So one of the things that these kind of studies do is they don't provide any new information on how well these things work for people. They really just provide extra ammunition for the physicians, the healthcare workers, and the patients to know maybe there's something that might be a little bit better in this circumstance. So it's really just adding information to help us make choices. So you can see here, this was a study that took, like I said, 1,800 patients who'd never been treated before, and a third of them went to one of three different combinations. So one of those they were all with the same backbone. So they were all with a Truvada backbone. Okay, so a tenofovir FTC backbone, and it was a backbone with either atazanavir, ritonavir, so Rayataz, a protease inhibitor, raltegravir, which is an integrase inhibitor. You may also know it as Icentris, or darunavir, or Prozista. Okay, so compared those three standard regimens. Those are all, approved regimens that are used regularly. And they wanted to see how people did after, about 2 years. And, one of the reasons I think it's important to talk about sort of these scientific studies at these kind of events is, often people who have very little exposure to clinical trials may not know, how clinical trials work. And I think it's interesting for people at times to sort of know some of the basics of these things. So, one of the basics of a clinical trial in HIV is sort of what are their usual endpoints, right? So what do they look for at the end of the study? And one of the things they look for here, you can see here, is a very common endpoint in HIV medication clinical trials is what we call virologic failure, right? So basically virologic failure means, quite simply, people who don't achieve an undetectable viral load. So after a certain amount of time on the drug that that's in the trial, if the viral load is not undetectable, then that's considered a failure. And that's sort of one of the main outcomes in these trials. So that's something to keep in mind going forward. Basically, again, ignore all the fancy colors and words, but the bottom line is that when they compared these three different regimens, these three approved regimens, it looked like the raltegravir-based regimen was slightly better. Okay, so raltegravir, which is the integrase inhibitor called Icentris, did better overall. So again, what do I mean by better? So again, remember that endpoint. The endpoint is virologic failure. So in terms of the 600 people in each arm who were on these medications, fewer of them in the raltegravir arm compared to the other ones had virologic failure. That's what that means. In terms of discontinuations, there were more discontinuations in the atazanavir arm. For those of you familiar with this drug, there are some GI side effects associated with it, so that's not surprising. Another thing to keep in mind, we always look at, how well does the drug work and how well do people tolerate it, right? So we want to know, we want it to work, yes, but we also want people to be able to take it. So another thing that we also need to look at in these studies, which is almost always looked at, is resistance. So resistance is important, if the drug works and people are tolerating it, but we know that it leads people to develop some sort of resistance that may compromise their future options for treatment if they ever need those, then that's also an important thing to note. So you can see here, so even though raltegravir did very well and slightly better than the other two, overall, in terms of how well it worked and how it was tolerated, there was slightly more resistance. That's an important thing to note as well. So this ACTG 5260, this was a sub-study of the study I just talked about. And really this focused on something called inflammatory parameters. So why is that important? So HIV is actually considered a chronic inflammatory illness. And that's important because inflammation is implicated in many different things. So one of the big things that inflammation is implicated in is cardiovascular disease, heart attack, strokes, other types of heart disease. So it can be an important, it not only can be, it is an important contributor to cardiovascular disease. So there's, over the last several years, there's been a lot of interest in determining whether or not we can reduce inflammation in people who are on treatment, but who are HIV positive on treatment. And there's been a very keen interest in looking at the different regimens to see whether a particular drug is better at reducing inflammation than another one is. So this is what this study looked at. So it compared the three different regimens, and the bottom line from the study is that what it found was that all the drugs acted on different things differently. So the three charts that you see on this slide are sort of three random tests that you can do to measure inflammation. And they do a whole panel of these. So the specific tests aren't all that important. But if you were to look at all these different tests that you can run, they're basically all blood tests. Different medications affect things differently. Some of them will reduce it a lot, will reduce one of the tests a lot, the other one won't. but overall there isn't really a big difference between any of the different agents. And the bottom line is that even in someone who has completely perfectly suppressed viral load, there's always at least so far, there always seems to be incomplete reversal of inflammation. So even if your medications are working really, really well and your viral load is undetectable, there's always going to be some element of inflammation when you measure all of these things. So that just begs the question, do we need, it doesn't beg the question, it leads us to think that we still need to keep looking for other ways of, completely reversing inflammation, recognizing the damage that it can do. So we're just going back in history a little bit. So a couple of years ago, there was this study that was done. It was a very small study, and it didn't have a comparator arm. So, anytime you do a study, you want to have a comparator arm. You want to compare it to something, either placebo or, in most cases, placebo isn't appropriate, so you'll compare it to standard therapy. So this was a single-arm study, so it didn't compare to anything, but it really wanted to look at this combination which excluded the backbone. So many of you probably know that when you construct a combination of medications to treat HIV, there's always a backbone, and then there's a sort of a third agent. So the backbones are either Kivexia or Truvada in most cases. You have their nucleoside reverse transcriptase inhibitors, or what we call nukes. AZT falls into that category as well. 3TC, there's D4T is an older one. So there are a lot of different medications that fall into that category. And historically, a lot of these medications have had problems with side effects and people tolerating them. So over the last several years, there's been an interest in the research world in finding different medication or different combinations of medications that excluded these nukes. So they were called, the terms that are used are, nuke sparing regimens. So regimens that don't have these nukes in them. So regimens that don't have those backbones, but they're constructed in a way that have other things that hopefully would work. And there's been, a lot of research that has gone into this and not a lot of success. So often when they look at these things, these combinations of medications that exclude those backbones, exclude those nukes, there hasn't been much success. So this was a study that was done, like I said, in 2011. It was a single-arm study, just a small study to see whether or not trying people on a nuke-sparing regimen that consisted of a protease inhibitor, so darunavir or Persista, and raltegravir, just those two medications, so darunavir with ritonavir, and raltegravir in people who'd never been on therapy before, whether using that combination worked. And it seemed to work in this small study. So then that paved the way for a bigger study, which was done properly with a comparator arm called the NEAT study. So basically this study looked at, again, people who'd never been on therapy before, and they were randomized, so they were sent to one of two groups. So they were sent to a nuke-sparing group, where they were on darunavir and raltegravir, or they were sent to a group where they were on standard therapy, so what you would normally get if you went and started HIV therapy. And they wanted to compare them. Their question was, we recognize that some of these medications aren't tolerated well, or people can't take them for whatever reason. They have, some pre-existing illness that prevents them from taking them. So let's see if we can come up with a nuke-sparing regimen, finally. Let's see if we can finally do this, because we've tried so many times. That works. So they designed this big study and took a look at things. And lo and behold, we'll ignore some of this stuff. It worked. So it seemed to show promise. And this was at, I believe the primary endpoint was at 48 weeks. No, 96 weeks. So almost 2 years. So I'm just going to, again, a busy slide, but I'm going to highlight one of the other sort of pearls of research that gets done in these cases. So, you have the overall number, and the overall verdict from the study was that when you constructed this combination of medications and you excluded the backbone, it seemed to do just as well as the other standard therapy. Another thing that they often do in these studies is they do these subgroup analyses. So they look at, not overall, they look at specific groups of people. So one of the things that is sort of a word of caution in this study is that overall, again, the nuke-sparing regimen seemed to work overall. But when you look at one particular group, down here, so those with a baseline CD4 count, so a CD4 count when they started of less than 200, so a low CD4 count, those people failed more if they were on the nuke-sparing regimen. So their failure rates were 39% versus 21%. So the bottom line from this is that even though overall it was promising and it looked good, maybe if you're actually, considering going on therapy and you fall into that category, maybe, you and your doctor should really consider this. If this is what you're considering, you should consider it. If your CD4 count were low, perhaps this isn't the best regimen for you. Because in those, when they looked specifically at those 123 people who were below 200, they didn't do as well. And so this slide kind of highlights one of the reasons why they look at these kind of regimens. So like I said, in many cases, let's say someone has some trouble with their kidneys. So in that case, often tenofovir, which is a part of Truvada, you wouldn't want to watch that. You wouldn't necessarily not use it. It's still usable. But you want to watch the kidneys maybe a little bit more closely, because we know that tenofovir can affect kidney function. Usually the pattern is it drops a little bit in the first few weeks and then it stabilizes out. And this is exactly what happened in this study. So you can see here, the orange line here is the group that was on standard therapy. So the group that had the backbone. So they had tenofovir on board. And you can see right here in the beginning, the orange line drops off a little bit. So basically you can see here that the orange line in the first 4 weeks, exactly, you can see the orange line dropped, and that's a drop in kidney function. It's a small drop in kidney function, but it's still a drop in kidney function. But over the time, when you stretch it out to 96 weeks, so almost 2 years, it's stable. So that was also reassuring because it fit the pattern that we expected. And this is just a screenshot of the. So that study was actually published in a big journal called The Lancet this summer, and the results of that were published at that point. I'm just gonna drop the pen here. All right, moving on. So again, these are naive trials. So these are individuals who've never been on therapy before. And this is this is the single study. So this is looking at one of the newer agents that's currently available. So it's broadly available, but it's probably the newest. It is the newest drug that's currently available widely. So it's dolutegravir or Tivicay. So that's also an integrase inhibitor, and it's well tolerated. It works well. So this is a study. This is the big study that was done, which showed how well it worked. And this basically was, again, folks who were never on therapy, and they were randomized to either the new drug with the backbone of Kyvexa or to standard therapy. And again, you can see basically when the lines are really close, it means they performed pretty closely. So you can see here that at the end of the 96 weeks, the dolutegravir arm, so the new drug arm, performed, had 80%. So 80% of the folks here had an undetectable viral load, which is a good number. And 72% of the folks in the efavirenz arm, or the atriple arm, basically, had 72% of them had an undetectable viral load. Because the numbers were so high, and they designed the study in a way that the math would allow this, they were able to say that based on this, dolutegravir was better. So the new drug was better and performed very well. The other thing that was important, recall that I said last time that it's important that the drug works, that people can take it without any problems, and that there aren't any other problems with it like resistance developing. So this was one of the key things in this study as well, is that in the dolutegravir arm and the Tivicay arm, there was no resistance that developed at all. Which means that if ever you needed to come off of that medication and go to something else, your options would be less limited if you didn't have resistance. So we've talked about one study that was nuke sparing, right, in an attempt to sort of limit side effects or whatever. And that study that I talked about, the NEAT study, was successful. So this is an example of a study that was not. So this is a modern study, and this again attempted to remove allow people to be on a regimen that didn't have any backbone, didn't have any nukes in it. And it was using a drug called Maraviroc, which is a bit of not an often used drug because there are issues with coverage. The government doesn't cover it easily, but it's a CCR5 inhibitor. So it has a different mechanism. It's the only drug currently available in its class. And the hope was that they could use this drug to develop a nuke-sparing regimen, and people would do well on it. So this study actually highlights another important part of clinical research is that, studies aren't started and then go to completion and then the results are reported and then they realize at that point that things didn't work. So there's ongoing analyses that go on when studies take place. So there are things called interim analyses where usually independent bodies come in. They're usually called something like the Data Safety Monitoring Board. They come in and they do analyses at various points during the study and see how the different arms are doing. So this is what happened with this study. This independent body came in, looked at some of the numbers and said, hey, this experimental arm where you're trying to do the nuke sparing thing isn't working and is performing more poorly, so we're stopping this study. So they actually stopped the study before it completed and said that no, people this arm of the study is performing at an inferior level to standard therapy, and we don't want this study to continue. So sort of one study showed that a nuke-sparing regimen worked when it was different drugs than this one, but this study demonstrated that the nuke-sparing attempt didn't work. Okay, and you can see here, so the lines here are a little bit further apart than some of the other ones. So basically 87% of people in the standard therapy arm had an undetectable viral load at week 48. Only 77% of those in the other arm had an undetectable viral load. And the absolute numbers aren't actually the important thing. It's when they compare these and run statistical analysis of the comparison and the difference that's important. If they see that the difference is significant, then it's significant, it's inferior, and that would be the reason for stopping. I'm going to gloss over quickly some of these, but they just bring up some important points here. So some of the new agents that were presented. So these are new drugs or new ways of delivering drug, which I think are important and interesting. So first off is this study called the Latte study. The slide's super busy, I know. Really, this study was important for a couple of different reasons. So this study itself isn't really the groundbreaking part, but this study set the stage for something else that's happening right now, which I think is going to be a game changer in the delivery of HIV treatment. So basically, this study was, again, your standard study. Another thing that this study highlights, if you look at the chart up here, you can see multiple dosages, right? You see four different red lines, 3 of which are sort of broken up in the middle. And you can see different dosages. So 744, 10 milligrams, 30 milligrams, 60 milligrams. So that's another thing that a lot of these drug trials do is they when they know something works, they actually look for an optimal dose. So this is what this was doing. So what is this? So this is a drug called 744. It's related to dolutegravir, the integrase inhibitor Tivicay that I talked about earlier, but it's not the same. It's an analog. Okay, so it's an oral drug. And what they did in the study is they gave a bunch of these people oral drugs. So they gave them this new drug, 744, along with a backbone. Okay, whatever that backbone was, they could choose for the first 24 months. And that was considered the induction phase. So that's the first part of the study. They gave them these drugs. And then they compared all of those again, like they do in any good research study. They compared it to standard therapy with efavirenz and a backbone. Okay. After 24 weeks, they switched it up. So they discontinued the backbone in those folks on 744, and they gave them rilpivirine, which is an NNRTI. It's the NNRTI that's in the drug Complera, for those of you who know that drug. And they continued that to 96 weeks. So again, you may look at this and say, who cares, right? It's oral drugs, they're giving them these drugs that exist, big deal. But the reason this is important is because 744 and rilpivirine have been developed into are long-acting injectable agents. Okay, so right now, currently ongoing right now, is these injectable studies. So the every 1 to 3 month injection of a medication that basically eliminates the need for daily pills. So this was a study. The latte study was the oral version of that, which sort of, they call it a proof of concept. So it proved the concept that these drugs would work if you take them, and then they developed this long-acting agent that you inject every, I don't think they've come down to the exact sort of injection frequency yet, but the idea initially was, maybe every 3 months you get an injection and that's it. You come back in 3 months, you get an injection, and you do that 4 times a year, and that's your therapy. You don't need to take pills anymore. So that study's ongoing, that injectable one, but this was a study that sort of set the stage, and this was presented this year. This basically just shows that it worked. There's multiple drugs. You can see 90s across the board. Those are the percentages of people who achieved viral load undetectability. So across the dosages, and then even in the comparator arm, everything sort of performed very well. Again, this is a crazy slide, but just know there's a new NNRTI out there. It's called doravirine. It's coming. That's all I'll say about it. I just wanted to highlight it. So now the final part of the drug stuff is switch studies. So these, shifting gears a little bit. So this is of particular interest to people who are already on therapy and for whatever reason want or need to switch. Too many medications, want to be on one, side effects, whatever. So these studies look at switching people from what they're on to something else for whatever reason. And again, the reason often doesn't really matter. So there was this study called the strategy study. It was actually 2 separate studies, the strategy PI and strategy NNRTI. And these were folks who were stable on therapy, either a protease inhibitor-based therapy, so darunavir, atazanavir, one of the protease inhibitors, or NNRTI, so ATRIPLA, which is efavirenz, or nevirapine, and for whatever reason were interested in switching, and they did. So they were either continued on the regular therapy, or they were switched to the combination medication elvitegravir, tenofovir, FTC, and cobicistat, also known as Stribild. From now on, I'll call it Stribild because it's quicker. And they just wanted to see how people did. So these are people stable on therapy, doing well in their therapy, want to switch it, and then they compared the 2 groups to see how they did. And overall, it worked. So if you're, based on this study, if you're stable on your therapy, but you want to switch it for whatever reason, and you switch to Stribild, in these situations, it seemed to work fine. People remained undetectable, tolerated it well. And this is just really, there was slightly, I think all this shows is that there was slightly more headache and slightly more nausea in the Stribild group. So overall, performed fairly similarly. So that really just, that's reassuring, right? So it's reassuring to know that if you're on something that's working, it doesn't matter whether you're tolerating it or not, even if you're tolerating it and you want to switch to something else because it's 1 pill once a day, that's reassuring. So that's one study that's reassuring. So this was another study called OLE, done in Spain, obviously. So this slide was made by someone else, and Fiona Smale, actually, and she actually included these photos here. So I don't take ownership of any of these photos. But basically, this was a slightly different kind of switch. So these were folks who were on standard therapy, 3 drugs, and they were switched to 2 drugs. So basically, you're dropping half of the backbone. So you're leaving them on 3TC, and you're dropping the other nuke. And these folks did fine. So basically what this showed is that when you dropped one of their drugs, in this case, you're not really switching them per se, but you kind of are. When you drop one of their drugs, they did just as well as those who remained on standard therapy. This finding was also replicated in another switch study called SALT. And basically, these again were patients on standard therapy, doing well. You drop half of their backbone, and it was safe, it was effective. out to week 48, people did fine. So the harness study was another switch study, but this time it was a nuke-sparing switch study. So people were on standard therapy, and you weren't switching them, you weren't just dropping one of their medications, you were actually getting rid of the backbone altogether and putting them on atazanavir and raltegravir. So this one didn't work out. So you may remember from a few slides ago, the NEAT study was darunavir and raltegravir, and that one was good, right? That nuke-sparing regimen worked. This nuke-sparing regimen didn't, unfortunately. So you can see here the rates of failure were 9.7 versus 2.7. So when you compare these two statistically, that was significant enough to say that switching folks to this nuke-sparing regimen was worse than having them on standard therapy. So finally, the final part of the switch section, and then we'll take a break, was a presentation done in Melbourne by some Canadian folks. This was presented by Marina Klein from Montreal on behalf of the CANOC cohort. So some of you may be familiar with CANOC. CANOC is a large, it's based in Vancouver, but it's a large observational cohort made up of people from across the country. So various clinics across the country take part in CANOC. And it's just basically this big database of people who are HIV positive and who are followed. So there's a ton of information on the folks who are followed. And it just provides a sort of almost a gold mine, I guess, of data from which you can look to see how people are doing, and you can do studies to look at how things have changed or how people have done under certain circumstances. So this study was actually specifically looking at people who switched their therapies. So specifically people who started antiretroviral therapy between 2005 and 2012. So in this big database, they have years of information, and the reason they started at 2005 was because that was sort of when the modern era of our current therapies was sort of under full swing, and they wanted to make sure that they were sort of comparing apples with apples. They didn't want to compare people who were started years ago when they were on sort of a different regimen than we would use today. These were people who were undetectable, so they were doing well on their medications in terms of virologic expression, but who were switching for whatever reason. So unfortunately, this study wasn't able to figure out why people switched, but we know that they switched. And then they looked at how these people did when they switched. So you may remember from the few slides that I already showed, in most cases, if in the studies that I showed so far tonight, in most cases, if you're suppressed, you're doing well in your therapy, and you switch to a standard therapy, it doesn't seem to make a difference, right? The strategy studies that I showed, etc. Even if you don't get switched to standard therapy, even if you get switched to something that's not quite standard, people still seem to do well overall in many cases. So what this study showed was that's actually not the case. So when they looked at these folks and they tried to figure out any predictors or risk factors for failing later on, so virologic failure meaning not being undetectable, they found that switching was associated with failing. So this kind of runs contrary to some of the data I presented earlier. So if you're one of these people who switched, when they did the analysis, they said, okay, well, switching makes you 1.35 times more likely. So not a huge number, not even twice as likely, but it's still a significant number when they crunch the numbers. It makes you 1.35 times more likely to fail than if you didn't switch. Other things that were involved here as well, you can see if you just go down the list here, persons who inject drugs here were almost 3 times more likely to fail if they injected drugs. So again, these are observational cohort. This is observational cohort data. So this is going into a database and extracting this data out. So it's not really following people in real time. So it's not perfectly accurate, but it's important. It's important information to get because it sort of maybe makes us a little bit more cautious about the whole switching thing. So the conclusions from this study were that switching is very common. Over a third of people actually switch the regimen when they're even when they're suppressed. So that was a little bit surprising, actually, because a lot of people do switch. Again, they didn't know the reason for switching, but it was presumed to be either toxicity, so people weren't tolerating it at all, or simplification. So, if you're on 4 drugs, you want to be on 1, you might want to switch, or drug-drug interactions. And again, switching from your first regimen. So again, one thing I failed to mention was that this was individuals' first regimens. Switching when you're doing well is actually associated with subsequent failure. So that's one thing to keep in mind. I have a slide up here that just as of July 2010 demonstrates some of the clinical trial evidence that was in place for prevention studies. So as of July 2010, there had been sort of 3 major studies looking at HIV prevention. There was a study on male circumcision. There was a study on treating STIs, recognizing that having syphilis, gonorrhea, chlamydia can increase the transmission of HIV. And then there was a Thai vaccine study. So there was a vaccine that had been developed and a trial done in Thailand. And just a short, so there were only sort of these 3 main studies that were done, had been done at that point. Fast forwarding not even 3 years, you can see way more. So this is where all of the PrEP studies, so pre-exposure prophylaxis. For those of you not familiar with PrEP, it's basically taking an HIV medication, specifically Truvada, in folks who are HIV negative. There have been multiple studies that have looked at this, but basically for HIV prevention. So there's different ways of doing it. Some studies look at it taking it daily. Other people look at it taking it intermittently. But overall, that forms the bulk of many of the studies that have come through in the last few years. And there's also this study which I'll highlight here, second down. If I can find my arrow, here it is. So HPTN 052. So HPTN is the HIV Prevention Trials Network, study 052, again, a meaningless name. But that was a study, it was a huge study. It was published in I think, 2012 in a big journal, the New England Journal of Medicine. And that was a study that demonstrated, it was a big study. It was looking at serodiscordant or serodifferent couples. So these were couples where one partner is HIV positive, the other partner is HIV negative, and looking at the impact of an undetectable viral load on transmission. And what they found in this study, this was a big study that was published that showed that, in those couples where the HIV positive partner was undetectable, that was 96% protective in preventing transmission. So that was the study. You often hear it quoted in a variety of things. But, when you think about how effective condoms are, when used properly, condoms are about 95% effective, right? So, this study demonstrated that simply having an undetectable viral load, so being on treatment and being suppressed, was protective against transmission. And this is a question I get a lot in clinic because, several of my patients have negative partners, and one of the first questions they often ask me is how can I prevent transmission? How can I protect my partner from transmitting HIV? So just to demonstrate, comparing these 2 slides, there's been a lot of progress done on the HIV prevention front in the last several years. So this study was presented this year at CROI in Boston, and it was a subset of the partner study. And basically, it was just looking at transmission of HIV by different behaviors. So you can see here, they have very specific behaviors down this line here. And the bottom line from this study was that they were just looking at the risk of transmission in these couples who were on suppressive therapy. They were, again, serodifferent, so serodiscordant, serodifferent. So one partner was positive, one partner was negative. And basically, overall, what this graph here shows with all the colored dots is that in basically every type of activity that they looked at, there were 0 transmissions. Okay? All right, moving on to IPREX. So IPREX is the big randomized placebo-controlled PrEP study. So the pre-exposure prophylaxis study that was done in MSM. And so that study ended, and this is a study that showed that PrEP was effective when you took it. So, overall the number was about 40%, in the 40s, but when they actually broke it down and looked at those folks who actually took the medication, it was about 90-something%, over 90% effective in preventing HIV if you took PrEP. So what they did after the study ended was they have this thing, OLE doesn't stand for OLE, the study I just talked about earlier. It stands for open label extension. So when the study ended, they continued it and they offered PrEP to everyone who was in the study, even those who were in the placebo arm. And what they found here, and really, the one thing we do know about PrEP is that it's, like I said, it works if you take it. So that's really how you have to interpret some of these studies, is that, overall the numbers might not be great. So in the 40% range, doesn't look that great. But when you actually look at those subset of people who took the medication regularly, it worked very, very well. This is what this chart shows. Basically, we know that adherence, we know that taking the medication is important in preventing HIV, but that we also know from this study that 100% adherence is not required. So you can see here, in those folks who took 2 to 3 tablets per week, so basically about 50% adherence here. So if you're taking them 2 to 3 a week, you have about an 84% protection. In those who took at least 4 tablets a week, so again, you're only taking it 4 to 7 days a week, that about 100% protection. So again, it's important to take it when you're taking PrEP, but it's perfection is not needed. All right. And sort of more recently, in late October of this year, there's another trial that was ongoing, mostly in France, but there was a little part of it that was happening in Montreal. It's called Hyper-Gay, and it's a placebo-controlled trial that was looking at PrEP, but different from the other studies that had been done in PrEP. This was intermittent. So instead of taking it every day, they had a sort of a schedule for taking it. So, you start the day before. If you're planning on having a busy weekend, you might take it, and then you take it for a few days, and it's intermittent PrEP. So this was different from a lot of the other trials that have been done because it was intermittent. And what it found was that, again, they did one of these analyses. The study wasn't done, but they were sort of examining things as things were going along, and they found that the benefit in the non-placebo group, so in those actually getting the medication, the benefit was significant enough that they shut down the placebo arm. So that happened just recently, just about a month and a half ago. They shut down the placebo arm of this intermittent PrEP trial, and now they're carrying on with just the treatment arm. And this is also very reassuring for some of the work that's happening now. So right now in Toronto, there's some PrEP stuff going on, happening mostly at St. Mike's. Again, Daryl Tan is the person running those, looking at providing PrEP to 50 high-risk MSM. That study has already started and currently recruiting, and really looking at not so much, definitely interested in how well it works, but more looking at the logistics of providing PrEP and really doing a lot of work around the provision of PrEP and seeing sort of how it works in a real-world context. These are just some, I thought they were interesting. They were presented earlier this year. There's some animal models of PrEP. And again, it's actually using that drug that I talked about earlier, the injectable drug, this 744. That's the long version at the top there. You can see the full name there. But 744 long-acting is the injectable form of the study that I was talking about, of the drug that I was talking about earlier. And these were just animal studies in monkeys, macaques, demonstrating that these long-acting injections are also effective as PrEP in monkeys. So, these are the early studies. Again, take all of this with a grain of salt, but in these animal models that are typically used as a very reasonable animal models for subsequent human studies in both vaginal and rectal transmission of HIV, this long-acting 744, this dolutegravir analog, seemed to work well for pre-exposure prophylaxis. I should have disclosed that currently PrEP, Truvada as pre-exposure prophylaxis in Canada is an off-label use. So it's not approved in Canada for the use of PrEP. It is in the US, it's not yet in Canada. So actually, if you use it in Canada, and many of us prescribe it, you're using it off-label. It's not illegal, but it's not officially recognized as an indication in Canada. The next slide here I have here is just another, I think, interesting, different way of delivering preventative HIV medications. So this is a vaginal ring. And they used a bunch of different medications, some of which are currently available in oral form. And what they found was that one of them in particular, dapivirine, which doesn't exist in oral form, worked fairly well when it was used in women. So again, this is just, I'm just mentioning these because I think they're interesting and they're sort of novel methods of delivery of some of these medications. So just something to keep in mind, and there's a lot of work happening in a lot of these different delivery mechanisms of HIV medications. And another one is this film. So a lot of people think it looks like a Listerine breath strip, but it's not. So this is it's basically a gel in film form, and it's to be used vaginally. So it's also showing some promise as well. All right, moving on to comorbidities. So now to something else near and dear to my heart, HPV. So I one of the things in my bio is that I work at the anal dysplasia clinic, or I guess it's past tense, isn't it? So I had my last clinic yesterday. I worked at the anal dysplasia clinic, or the anal cancer screening clinic at the Toronto General Hospital. So this area is, I think, an emerging area. It's an area of increasing concern with respect to the health of mostly MSM who are HIV positive, and MSM who are HIV negative as well. It's a concern, and women as well. So this is HPV is really an emerging issue, and I really think a lot of efforts are going to be put into figuring out a lot of this stuff in the next few years. So just to give you a bit of background on HPV, it's the most common viral STI worldwide. It's responsible for pretty much all cervical cancers, pretty much 100% of cervical cancers and over 80% of anal cancers. And just to give you some perspective, so anal cancer rates, the absolute numbers aren't huge, right? So in the general population, 2 per 100,000 will have anal cancer. But when you actually look at, you break it down by MSM populations, that rate goes up to 44, so a 22-fold increase, 44 per 100,000 in HIV negative MSM. And if you look at HIV positive MSM, the rates are greater than 100 per 100,000. So basically a 50, and some estimates are even higher, so 160 per 100,000. So a 50 to 80-fold increase, just by virtue of being HIV positive and MSM, increases your risk of anal cancer by that much. So obviously there's a need to figure out some of this stuff, right? There's a need to figure out ways of screening, benefits of treatment if someone has changes from HPV in the anal canal, for example. Most of these, there's over 100 different types of HPV, and they're all numbered. So HPV 1 all the way to 100 and something. So the most concerning ones are HPV 16 and 18, and both of those incidentally are included in Gardasil, which is the HPV vaccine. And then there's other players as well, a handful of other ones which are considered cancer-causing. Not all HPV causes cancer. So type 6 and 11, for example, are responsible for 90% of genital warts, but they're not implicated in cancers. It's really 16 and 18 are the big players. Recognizing all of these things, that this is an emerging problem, especially in MSM, and that we don't have a lot of data on sort of how to manage this problem, period. And the other big challenge is that there are very few people trained to do this kind of screening and this treatment. So there are 4 of us at the Toronto General. There are 2 people in Montreal, 1 person in Ottawa, 1 person in Calgary, 3 people in Vancouver. And I think that's it. So nationwide, there are about 10 people who do this. And there's very limited clinic space. And if the problem is really emerging and is going to become that much bigger, something needs to be done. So one of the studies that this was actually not presented at either of those 2 HIV meetings that I mentioned earlier, but this was presented at an HPV meeting. I presented it on behalf of the team that did it. So it was Irv Salat at Toronto General, who was the principal investigator in the study. And this was a study really just looking at the screening and treatment of anal dysplasia. So anal dysplasia just means changes. And what happens is, when HPV infects a tissue, so if it's a cervix or if it's the anal canal, it causes changes. And those changes can either be high grade, which are typically considered precancers, or low grade, which are not normal, but they're not precancers. So basically, you can think of it as a continuum. So you have normal tissue, low grade changes, high grade changes or precancer, and then cancer. One isn't necessarily going to go to the other. The progression rates are not really known well in anal cancer. And if you have high grade, it doesn't mean that you may never develop cancer. But again, we don't know a lot about the progression rates. So this study was really meant to look at a number of different things. So one of the key things it was looking at was it wanted to examine response rates to an invitation to anal cancer screening. And why is that important? Right? So if you send out an invitation or your family doctor says, hey, you should get screened for anal cancer, how many people would actually say yes to that? And one of the issues with it is that Cancer Care Ontario, one of the big cancer agencies in Ontario here, does this. They send out invitations for a variety of different screenings. They spend millions of dollars on postage alone, and the rates of acceptance to many of these things are less than 10%. So the return is not huge, and people don't accept screening very readily when it's just mailed out with no sort of stuff in the middle. Right? So one of the things that this study was looking to do was to look at how people would respond to anal cancer screening. So it's one thing to think we should do it for everyone, but are people even interested in doing it? So that was a big question we wanted to know. And then to look at factors that are associated with uptake. So if people do say yes, what led them to say yes? Why did they say yes? If they said no, why did they say no? So these were all important things in eventually developing a broad scale program of anal cancer screening, recognizing that it is a significant health issue. And a few other things were aims of the study. So one of them, for example, so if any of you are familiar with Maple Leaf, many of the doctors there were involved in that study, and part of that study was teaching those family doctors to do anal pap smears, which is relatively easy, but it was one way to sort of build capacity a little bit. So basically, it was a small study, and with the aims that I already mentioned. But another one of the aims as well was to look at treatment outcomes. So one of the things that was done in the study was that people had pap smears done. So these men had pap smears done. And if they were abnormal, if they had high-grade changes on their pap, they were actually sent to the clinic for high-resolution anoscopy, biopsies, and treatment if they had precancers noted. Okay? So one of the sort of, benefits of having been in the study was that they were sort of entered into treatment if that was needed. So these were all unscreened men, all HIV positive MSM from 9 different primary care practices, mostly at Maple Leaf, but I think there were a few that were outside. And pap smears were done initially. So this is what it looked like. So the invitations were mailed, but one of the key things here is that the invitations weren't only mailed. They were typically people had a discussion by their primary care physician as well. So there was that extra little step there. And you can see here that the acceptance rate was a whopping 56%. So way better than what we see in general invitations for screening. And that says a lot, and that's important, right? Because it says that if ever this was to be rolled out in a broad way, which, eventually probably should be, if we ever are able to do this in a widespread way, it looks like there would be a lot of interest. At least 50% of people would be interested in doing this. So when we did this, 1,700 invitations were sent out. 970 people accepted the invitation, which means they accepted to have a pap smear done. And of those people, 8%, or 77 individuals, had high-grade changes. Okay, so when the pap was done and it was sent to the pathology lab to get read, 8% of them, 77 men, had precancers on the pap smear. So those people were all sent, or at least all offered, further, more comprehensive examinations. So the precancer that I keep talking about on the pap, so when you do a pap smear, I said, it can be normal, it can be low grade, it can be high grade. High grade's typically precancer. We typically just refer to it as precancer, and that's called HSIL. So it's not important what it stands for, but that's sort of the high grade lesion that you would see on a pap smear. The problem with HSIL is, so another complicating factor in all of this anal cancer screening stuff is that HSIL isn't, a pap smear itself isn't a great screening tool alone. So what do I mean by that? So if you do a pap smear in, 900 people, 8% of them are going to have high-grade changes. So what does that mean? That means that those guys definitely have something going on, right? They need further exam. But the other thing is it's going to miss some people, right? So there are some people who are going to have a normal pap or a low-grade pap who are going to have significant disease that would typically require treatment. If you were to do an exam in some of these people and take biopsies, so take actual tissue and look at it under the microscope, you would find precancers in some of these people that the pap didn't pick up. Okay, so that's one of the problems with the pap, is that if you just rely on the precancer finding, if you see all these guys and you do paps and you only take those people with a precancer on pap and send them for further treatment, you're going to miss some people. On the other hand, if you take people with any abnormality, so if you take everyone who doesn't have a normal pap, so anyone with low grade or high grade, you're going to be probably seeing too many people, because a good majority of the people with low grade disease are not going to have any problems. Right? So you need to find an additional thing to do, and it's just, given the limitations on the number of people who do this, it's a challenging problem right now. So we don't know how to address that. This precancer, this HSIL, another issue with it is that it's complicated. It's a pathologic diagnosis. So it's the pathologist who makes the diagnosis. You do the pap smear. So what you do is you put basically a long Q-tip into the bum, and you move it around a bit. You shake it in some liquid. You send that to the lab. The pathologist makes a slide and looks at the slide under the microscope and says, okay, those cells are abnormal. Those are high-grade cells, right? The problem is that it's not very well standardized. So there's a lot of disagreement even between pathologists about what constitutes high-grade changes or precancerous changes. That's problem number one. So it's a challenging diagnosis to make. The other thing is the stability, and I allude to this on the slide here, is that HSIL, or precancers, aren't necessarily super stable. So over time, they might not remain, they might clear on their own. And there's a recent study that I won't get to, it's in the slides that follow, but a study from Australia that showed that even in folks who don't have anything done, so typically here in Toronto and in many other parts of the world where they do this kind of treatment, when we see HSIL, when we see a precancer, we're going to treat it. We're going to use infrared coagulation, which is kind of a laser type thing, or we'll use a strong acid, like a strong version of compound W, basically, and we'll treat the areas that are abnormal, and then we'll rebiopsy a few months later to see whether things got better. But in Australia, they're doing a study now where they're just monitoring people. They're doing very intensive monitoring, and they're doing biopsies, but they're not doing any treatments. And what they found in their study was that up to 40% of these HSILs, up to 40% of these precancers are clearing on their own without any intervention. So that is reassuring, right? Because it's reassuring in that, maybe these things don't progress as much as we thought. But it's also complicating and confusing because it just adds a little bit more uncertainty to how we manage these things. So as part of the study, focus groups were also done, just to determine why people accepted screening or why they rejected screening. So a big factor that came up in these studies was trust in their primary care physician. So again, it's that relationship with the primary care physician, the fact that this service or this screening was being delivered as the point person or the contact person was the primary care physician. So that relationship that already existed was a predictive factor in making sure that people accepted. That's why that's one of the reasons why it was felt the acceptance rates were so high. And then why did people refuse screening? So there were a number of different reasons. Didn't want to have a test that targeted the anus was one of them. You know, in places like Maple Leaf, for those of you familiar with Maple Leaf, there's a lot of studies that go on there. So people get research fatigue sometimes and don't want to be part of studies. All right. You know, I think I'm going to end there. I had a few more slides on HPV, but I think in the interest of time, and you've been listening to me for a long time and you've been all very patient, I'm going to stop there. And I will go to my last slide and say thank you for your attention.